introduction. And thank you, Dr. Ala, for your very nice lecture. You save a lot of my time for this lecture.
You have 25 minutes.
Actually, we are living in the era of epidemics of diabetes. Diabetes all over the world is increasing more and more and more, and this is actually the cost of civilization. McDonald's, Kentucky, Pizza Hut, cars, elevators, sedentary life, air condition, a lot of factors that increase the incidence of diabetes in the more civilized countries. So you find here that the incidence of diabetes in the North America and the European countries is very high in comparison to Africa, with the increased global world projections from the year 2000 to the year 2010 by about 46%. And if you are looking here, this is the prevalence of diabetes from the year 1995 to expected 20 to 25. This is the Western Pacific, Southeast Europe, but in Africa is still very low, because this is the cost for civilization. You'll find that in all of the Western countries, the prevalence of diabetes is very high. And this is expected increase. Within 30 years, the prevalence of diabetes will increase by about 100%. What is the consequence of increased prevalence of diabetes? There is 2 to 4 times increase in the cardiovascular risk, up to 10% congenital malformation of the offspring of diabetic mothers, and 3 to 5% fetal mortality. 15 years short life expectancy than for non-diabetic patients, leading cause of blindness and amputation, and also the 6th leading cause of death. And if you look to this slide, you'll find that the death from stroke and the cardiovascular disease started to decrease. Cancer is the same, but diabetes is increasing more and more. So the risk of mortality from diabetic patients is very high. And about 40% of cases of end-stage renal disease are attributed to diabetes, which means there's a lot of cost for the prevalence of diabetes. You find here that the incidence of end-stage renal disease resulting from primary disease, about 43% from diabetes, 23% from hypertension, 19% from glomerular disease, and the other diseases are responsible for the remaining factor. So diabetes per se is responsible for about 40% of end-stage renal disease. Also, regarding the epidemiology, the type 1 diabetes, 25 to 45% will develop diabetic nephropathy. And 80 to 90% with microalbuminuria progress to over diabetic nephropathy, 80 to 90% of type 1. And also 100% of patients with microalbuminuria will develop the end-stage renal disease within 7 to 10 years. So the incidence of diabetes in type 1 is very high. And this is a matter of duration. In type 2 diabetes, 50% will have microalbuminuria at the time of presentation, because the diabetes can appear at any time, but the later diabetes for a long time before. A patient can develop diabetes for 3 or 4 or 5 years, and he doesn't know that he has diabetes. And the 10 to 20% of microalbuminuria will progress to nephropathy. This is the risk factors for diabetic nephropathy regarding age, race, history of microalbuminuria, hypertension, poor glycemic control, smoking, and family history of nephropathy. Family history of nephropathy is very important, because sometimes you find some diabetic patients with poorly controlled diabetes and they don't develop nephropathy. And sometimes you'll find that patient with strict control of diabetes and they develop nephropathy. This is the role of family history of nephropathy, which is very important. Urine analysis and used as initial screen for all patients is very important. Negative or trace proteinuria requiring test of microalbuminuria. If you will find by mistake that the urine analysis is free, is negative, you must check for microalbumin, which is very important. And after that, 1 plus for greater proteinuria requires quantitation of proteinuria, and once the patient has microalbuminuria, testing for glucose proteinuria must be adequate and must be done yearly. I want us to give you teaching on this area. According to the American Diabetic Association in 2014, now the term of microalbuminuria is obsolete. They replace this one by mild to moderate and moderate to severe albuminuria. Why? In the past, the stage of microalbuminuria is the only reversible stage of diabetic nephropathy. And you can give at that time ACE inhibitor or ARBs, and you can reverse diabetic nephropathy. However, kidney biopsy had been done for a lot of patients with microalbuminuria. What they found that about 75% of those patients have glomerulosclerosis, which means irreversible damage of the kidney. So, this is not a stage of reversibility. This is a stage of structural damage. So the stage of microalbuminuria now is replaced by mild to moderate and moderate to severe albuminuria. But here I put albuminuria, microalbuminuria, just to be near for your memory about the history of microalbuminuria. Screening of microalbuminuria is very important. Must be done for all patients more than 12 years and at least once per year. You must start ACE inhibitor if glycemic control is adequate and still there is increase in urine albumin creatinine ratio between your mind. If there is urinary tract infection, don't consider this as microalbuminuria. If there is a high blood sugar, don't consider this as microalbuminuria. You must control blood sugar, you must control UTI, and you must be a patient noted with severe exercise. When you exclude all these factors and still there is microalbuminuria, you must repeat once per year, and you can give ACE inhibitor or ARBs. ACE inhibitor therapy appropriate in both normotensive and hypertensive patients with diabetes, not only for hypertensive patients. But if you have patients with normal blood pressure and microalbuminuria, you can give ACE inhibitor or ARBs. And the monitor albumin creatinine ratio will be 6 to 6 months after initiation of ACE inhibitors. Regarding the risk of microalbuminuria, as I said, this is a disease duration. However, there are some points to be sure that microalbuminuria is due to diabetic nephropathy. If there is proliferative retinopathy with fixed microalbuminuria, this means diabetic nephropathy, because this patient has microvascular disease. Retinopathy, nephropathy, could be neuropathy. But it's very important, if there is proliferative retinopathy plus fixed microalbuminuria, the diagnosis is diabetic nephropathy. However, there is about 30% of patients with type 2 diabetes develop nephropathy without retinopathy. But those patients are liable to renal biopsy. The kidney biopsy is indicated. If there is microalbuminuria without diabetic retinopathy type 2 diabetes, kidney biopsy is indicated. If the duration of the disease is less than 10 years, you can do kidney biopsy for those patients because you can find another cause for nephropathy other than diabetes. The increased rise of serum creatinine is very gradual in diabetic patients. And when the loss of creatinine clearance is about 1 milli per minute per month. If you will find rapid increase in serum creatinine, you must search for other causes. Could be urinary tract infection with papillary necrosis, could be obstructive uropathy, could be exposure to contrast media, medication like an ACE inhibitor or a COX inhibitor, hypovolemia due to diuretic overuse or any other cause, uncontrolled hypertension or congestive heart failure. So if you find rapid increase in serum creatinine in diabetic nephropathy, you must search for another cause other than diabetic nephropathy. Regarding the hemoglobin A1C, to know what is the importance of control of diabetes, control of diabetes, decrease of hemoglobin A1C by 1% can lead to decrease in diabetic-related deaths by 21%, decrease in incidence of myocardial infarction by 14%, microvascular complication, including nephropathy, neuropathy, and retinopathy by 37%, decrease in amputation or death from peripheral vascular disease by 43%. This is with only 1% reduction in hemoglobin A1C. So control of diabetes is mandatory. Just I give a hint about the pathogenesis of diabetic nephropathy. Here this is the afferent arteriole, and this is the efferent arteriole, and this is the average blood pressure. The main function here for the afferent arteriole is to increase resistance, to avoid transmission of this pressure to the glomerulus. So we must keep an intraglomerular pressure around 45 or 50. So to protect the kidney from this blood pressure, there is vasoconstriction here or increased vascular resistance to protect the kidney, the glomerulus from this pressure. If there is hypertension, sometimes the blood pressure, this afferent arteriole, intense vasoconstriction of afferent arteriole will increase resistance, and the afferent arteriole is not enough to prevent the transmission of this high pressure to the glomerulus, which lead to increase in intraglomerular pressure. If this hypertension is still uncontrolled, because there is severe vasoconstriction here with ischemia to the glomerulus and gradually glomerulosclerosis and the hypertensive nephrosclerosis. So you must help the afferent arteriole to keep the intraglomerular pressure normal. This is what happened with hypertension. But what happened with diabetes? If there is diabetes, all of us knows that there is increase from glomerular filtration during early diabetic stage, which means that the pressure here increased, but there is severe vasoconstriction of the afferent arteriole to protect the glomerulus from the high pressure with diabetes. So this is the diabetic stage. The hyperfiltration here, increase in intraglomerular pressure, can lead to a stage of microalbuminuria or glomerulosclerosis. But if we add here hypertension, and there is trial here for severe vasoconstriction to protect the glomerulus from this high pressure, it can lead to severe ischemia and severe sclerosis. So the addition of hypertension to diabetes can lead to hyperfiltration injury. Hypertension can lead to transmission of the high pressure to the glomerulus, and the end result is marked increase. The end result here is marked increase in the intraglomerular pressure with glomerulosclerosis and proteinuria. So, if you control diabetes, you will control hyperfiltration. If you control hypertension, you protect the glomerulus from this high pressure. So, you must control diabetes and hypertension in a significant manner. This is a regular loss of kidney function 1 milli per minute per month with diabetes. With uncontrolled hypertension, we'll find that the decrease will increase by from 1 to 2 milli per minute per month. So the deterioration of kidney function is more rapid with the uncontrolled hypertension. I don't want to, but this is summarize anti-hyperglycemic medications. I don't want to summarize this one after Dr. Ala, but what I want to say here, now you can attack hyperglycemia and diabetes from several aspects. Could be through the stimulation of beta cells of pancreas, could be from decrease in appetite, from incretin effects, could be from increase in insulin sensitivity, could be from increase in stomach movement, and so on. So you can attack hyperglycemia by a lot of mechanisms. But not all these medications are enough or reliable to be given for diabetic patients with chronic kidney disease. And chronic kidney disease, this is what happened for the abnormal glucose metabolism. The deficient catecholamine release lead to decreased renal gluconeogenesis and can lead to hypoglycemia, decreased renal insulin degradation with decreased insulin clearance and increased half-life time of insulin can lead to hypoglycemia. Uremic malnutrition also can lead to hypoglycemia. So these factors can lead to hypoglycemia. And the other factor can lead to hyperglycemia. So as Dr. Ala said, there is this dysglycemia with diabetes. Because those patients liable to hypo or hyperglycemia. And when patients come to you with chronic kidney disease, and they say with diabetes, and said to you, doctor, now I'm not totally cured from diabetes, I stopped taking all medication for diabetes. It's not good for you. Because when you ask this patient about history of diabetes, the patient can say that I have diabetes since long time, for 10 years. But gradually I found that there is hypoglycemia and tried to decrease the medication gradually, and now I am totally free from medication for diabetes. I'm not happy. Because at that point I'm asking him, please check for kidney function. Check for serum creatinine. Because if there is renal impairment, there is decrease of insulin degradation, increase of half-life time of insulin, and this can lead to yes, you can stop medication because the half-life time of insulin is increasing. So if the patient stops the medication by himself and still blood sugar is okay, you must check for kidney function. This is what Dr. Ala said about a physiologic serum insulin secretion profile. And there is the basal insulin. Basal insulin, as we know that our pancreas is producing the basal insulin. Basal insulin about 0.5 unit per kg per day. What about basal insulin? Basal insulin means this is for the basic activities. Activity of the heart, mobilization, and daily activities not related to meal. And then when you are eating, there is another push of pancreatic insulin. But the basal insulin, or basal 0.5 unit per kg per day, this is for the daily activities, not related to meals. But the pancreas also is producing another gush of insulin with meals. This is what we are saying, and we can give bolus insulin for that time. But this is the basal insulin, and then with meal, the pancreas is increasing the secretion of insulin. This is what I'm saying now, and if you give basal insulin, it will cover this area. Basal insulin is a peakless insulin. So it can be given without meals, because it's a peakless. It will not cause hypoglycemia. But before meals, if you will eat, you must take short-acting insulin to cover the postprandial period.